All right, let's begin. Good afternoon and good morning to those of you who are joining us. I'm Marvin Ventrell. I'm the CEO here at NAATP. I'm joined today by Greg Williams, president of Third Horizon. Greg and Third Horizon are our tech partners as it concerns tick data, transparency and coverage data. They're the tech experts that enable us to actually see this data. And that's what we're talking about today. We're talking about the tick data using NAATP's reimbursement benchmark reports to strengthen payer negotiations. This is one component of a bigger project here at NAATP, which we think of generally speaking as payer relations. We believe ultimately that the success of our providers and the wellness of those seeking treatment, getting access to care, is dependent upon fair, appropriate, equitable, in-network reimbursement rates. And as it exists today, those rates are very varied and probably not based on value as the insurers and we would like them to be. In order to get where we need to go, we need to do a couple of things. We need to work with our payers, and we do that, and we try to establish good relationships. We encourage our members to have collegial and not adversarial relationships with the payers, and we're making progress in that regard. At the same time, I would say to the payers out there that we're also going to hold your feet to the fire as it concerns following the parity law and reimbursing based on good benchmarking data, which includes claims data that is relied upon by our payers, but more than that as well. So toward that end, last year we released our first transparency and coverage report. It was a national report. It was last fall, and it reveals from the data that is mandated by law that payers put into the federal repository. It reveals information that's not been seen before. The the goal is to just level the playing field and create fair negotiations so that when you are negotiating with your payers for your rates, you know what folks are being paid across the board. That exists in all economies pretty much except ours. And so it's good that we've finally gotten to this point. So our job here at NAATP is to help our members be successful. So this is one of the kinds of resources that we provide. It's also to improve systems that enable that success. And then the third prong of that is to provide access to care for everybody who needs it. And this project and these reports really go to all three of those prongs. So this year we've released the first four of our state reports. We've released, and Greg's going to talk about those today in relation to the national report. We've released specific reports for the states of Illinois, Pennsylvania, Florida, and California. Our members have free access to the national report. They have access for a fairly nominal fee to the state reports, and non-members can access those things at a much higher rate. What we're hoping happens through much of our work is that those folks who provide good care out there, who are not members of NAATP, understand the value of this community that brings all the providers together, and rather than buying our products, join the community and be part of the solution. So I'm going to say one more thing and then turn it over to Greg. These reimbursement rates need to be based, as we say, on quality of care. You know, as we move as an industry away from fee-for-service programming to value-based care, that value-based care is embedded in value-based contracting, and that needs to be marked against fair metrics. What are those metrics? Well, there are lots. Going back to healthcare providers is one of them. That's the claims data. But the others are wellness measures across the board, including, of course, abstinence, but many other measures can indicate wellness and recovery as well. That's the other side of the coin. That's the FORCE program. NAATP runs the Foundation for Recovery Science and Education, FORCE, directed by our director, Dr. Annie Peters. Force is a program that collects data from data sites. There are currently approximately 70 NAATP members who are data sites. You must be a NAATP member to be a data site. And we collect that data and analyze it in all kinds of ways and feed it back. We produce a national report and a number of other resources that are available to data sites simply by virtue of them being data sites. It doesn't cost them anything as part of their membership. That's what they get. We call those core benefits. We also then have add-ons that are costly for us to produce, but we're happy to produce those, and those fee-based benefits can be purchased by Force data sites, who again are members. So again, it's part of the reason why we believe that we're all stronger together. And if you're at this webinar today and you're not an ATAP member, we would encourage you to talk to our membership team about that. So that's more than enough from me. We're really lucky here at NAATP to have Greg Williams working with us and Third Horizon. They do this better, I think, than anybody does it. I say that without reservation. Greg and I have worked together for many years now, and I'm happy to turn it over to you, Greg.
Thanks, Marv. Really grateful to be here. Just first and foremost, I'm Greg Williams, person in long-term recovery, and the reason why Marv and I have worked together for a long time is I've found my recovery through addiction treatment and quality addiction treatment, and I have been passionate about access to recovery supports and long-term recovery throughout this journey. And my own personal journey involved out-of-network challenges to my own reimbursement. And so I lead with just sort of that to kind of frame some of what we're looking to do today. And I know in-network versus out-of-network is a big decision point for many providers. And I know many providers aren't in touch with their big insurance carriers in their states, and some are. And we had a real opportunity in the last couple of years that we've never had as a field. And so historically, since the Parity Act was signed in 2008, that kind of required in-network and out-of-network coverage for mental health and substance use. Subsequently, the Affordable Care Act that made substance use disorder an essential health benefit, in large part to the advocacy of NAATP and other stakeholders. We've had an opportunity to access insurance. The big challenge in our field is that unlike most other health conditions, Medicare, the public national insurance company for those over 65, publishes a benchmark, and they publish a benchmark for all different conditions, surgeries, laboratory, all of that. But for facility-based addiction treatment, there is no Medicare benchmark for SUD. And in the absence of that, the commercial insurance carriers often haven't totally known how to price, because the way that they work in the rest of healthcare is they look at the Medicare benchmark and then they price and negotiate kind of relative to the Medicare benchmark. But as a result of having no Medicare benchmark, it's really left a very fragmented, confusing field of reimbursement for facilities, and what is the right price for residential or PHP or IOP. And a couple years ago, the federal government passed a rule called the Transparency and Coverage Rule that Marv mentioned. It requires every commercial health insurance company to publish all of their contracted rates in network for every code. So if you have an in-network contract, despite what your contract might say in terms of its confidentiality and its proprietariness, and you're not allowed to tell your spouse or your siblings how much Aetna, Blue Cross, Cigna, United's paying you, Aetna, Blue Cross, Cigna, and Aetna are publishing it on their websites, publicly available. Not accessible, but publicly available. And so what we did at Third Horizon is we built engineering capabilities to then access that, because it's in a file that is incredibly large called the machine readable file. Your AI tools that you have on your computer can't unpack these files. Trillions and trillions of lines of data. And we've been able to mine these files and extract the information around what historically was confidential reimbursement rates and be able to benchmark them. And so it's a real new opportunity to be able to see the market for addiction treatment in a new way. And so we are grateful to partner with NAATP on this work over the last 6 months or so, and being able to kind of highlight through the payer committee at NAATP the right facility types, the right codes. I'll talk about the methodology in a minute, but be able to extract data so that hopefully it can inform your work and inform your strategy. With the goal that we know many people operate out of network, and that certainly may be reasonable in certain instances, but the field and reimbursement is moving towards in-network, value-based care, recovery outcomes, quality. And so over time, we're going to see some of this out-of-network reimbursement models start to shy away to much more standardized in-network models as we see in physical healthcare. And so what we were able to do in the national benchmark report is identify about over 8,000 different provider types from different states. The Blue Cross Blue Shield network is really complicated. It's 37 localized plans. We've stitched it together into one network. So if somebody has the blue card, that's what you're seeing throughout these material. United Healthcare's rates throughout include Optum. So we've married Optum rates into this so that you can get a picture of folks with United. Even if your contract is with Optum, it's owned and controlled by United. Cigna, and then Aetna. Cigna, some people are doing contracts with a company called Evernorth. Cigna Evernorth rates are included here in the benchmark report. And these BUCAs, as we call them, basically make up over 50% of all employer-sponsored insurance beneficiaries across the country. And so it's a really strong representative of who, large employers and other fully insured networks and what the coverage looks like across these large health plans. And what we did in order to make it digestible, we took that trillions of lines of data and isolated it by levels of care. And so that you could see it based on the predominant levels of care that are offered across the ASAM levels by NAATP providers. So our intensive outpatient services, partial hospitalization services, residential treatment, withdrawal management. And then we did do, I won't talk a lot about it today, but in the reports, you'll see ASAM level 4.0 hospital rates. And we did that just as a comparative so that folks in their negotiations can be able to articulate the benefit and the cost benefit of using facility-based, community-based treatment services in lieu of hospital-based treatment services based on what these insurance companies are contracting for inpatient hospital. And then what we've done from a methodological standpoint, as I mentioned, so we have a platform, it's called StarSet Analytics. It's our in-house price transparency data platform, and we take complex data and make them digestible around these insurance. We filter the data. There's a lot of noise in this data. If anybody's dabbled in this data to date, there's lots of code combinations with providers that don't make sense. There's lots of one penny rates and other things. So there's quite a bit of filtering and actuarial rules that we have to apply in order to remove outliers and get to what we feel confident are about benchmarks. So behind me are data analytics professionals, actuaries, folks like that who are poring over the underlying details of this. And then we're restricting our outliers for this case so that we're able to kind of isolate what is the middle of the market. So you still see the high side of the market and the low side of the market, but sometimes you get wild noise in these files. And so we're restricting kind of the far outliers in order to make sure that our medians and our modes and our averages reflect what we believe is the market right now. And again, this is not our opinion. This is what is being published by the insurance carriers. And so you may see some things throughout that are head scratching. You may see some things throughout that might not totally make sense. Oftentimes there's some challenges in the underlying data, and we'll go back and investigate. And we had that instance in Illinois recently where a carrier was publishing something that was incorrect. And so the challenge with this data set is that we're only looking at in-network. These are the most reliable files that the carriers are publishing. So these aren't the out-of-network rates. These are those that have chosen to go in-network. And we're using representative plan files. So we'll take a national plan file and deduce that it's a representative plan product through lots of research and analysis. But every insurance company offers 17 different flavors or 1,000 different flavors of their network or their plan product with, HMO, PPO, POS, you name it, EPO. There's all these different flavors. And so sometimes there's differences in who's in network, who's out of network, or even what they're paying through different plan products. But we've aggregated that together so that you can see a crisp output. And we don't know the underlying contract details. What's published is that there's an in-network contract in real time between this carrier for this rate and this provider, but we don't know sometimes if it's a bundled rate or there's a quality pay for performance on top of that. We don't know if there's other contractual readmission policies involved in the contract. And so there is a blind spot in terms of we're publishing numbers, but we don't have all the contract details that are in the public domain that might govern some of how reimbursement is actually happening at the local level. And then the utilization management and medical necessity and all of that isn't included in these files either. So let's dive into the actual numbers, and I'll go through kind of how the national report is structured. Then I'll show you some highlights from each state. And then at the end, dive into some questions and discussions. So looking forward to that. And so what we've done here for IOP at the national level, you see we've taken revenue codes, HCPCS codes, S codes, combined them. We're only using addiction treatment provider taxonomies, meaning the identifying provider type that you all register with in your state for your license or your in-network contracts. And so we've isolated these rates, even though there's some mental health facilities and other provider types that might use these codes. We've isolated the code output to addiction treatment providers to be specific for NAATP membership. And so you see we publish all the rates by average, mode, upper bound. And so the average is obviously everybody kind of understands an average. A mode is what we like to look at pretty closely. That's the rate that is found most frequently. And so, you see that United Optum's national average is 222, but most often they're paying 250. And so it's really important. And sometimes you see, it go the other way around, but that mode, a lot of times is their opening offer, or what they're just trying to pay everybody. They've set a policy and they say, this is what we're trying to pay everybody. And so the mode is a really instructive measurement to think about, even better than average in some cases or median. Our upper bound is obviously where everybody would like to be. And that's in our I believe it's our 75th or 80% percentile of the negotiated bounds. And so you see A lot of the carriers for IOP, their rates are pretty stable in that upper bound where they're paying across the country right under $400. And then as we all know, there are providers out there that have a great rate for a great level of care. And so we also published kind of some top negotiated rates that we were able to find and verify in the files. Uh, for PHP, you'll see that there's more variability. This is a level of care I don't know that everyone has in their contracts. It's a little bit less stable, if you will, than a residential level of care or an IOP in the data. In terms of some carriers, really highlight paying for this, and other carriers less so. But you certainly see on the top negotiated rates a pretty big variance, and the modes. Blue Cross is certainly one of those carriers that we see really a lot of variance depending on which Blues plan in which market and how they're treating PHP, where you see some more consistency in the Aetna and Cigna network around PHP. And for residential, we see a lot of stability here. This is obviously the core service that many NAATP providers offer, is the ASAM 335 level of care. Lots of different rates are used across the different carriers between revenue codes or HCPCS codes. Some of these you may use, some of these you may not. But different carriers kind of use different codes that they go to. But you can see a pretty significant similar picture, where the mode is sitting right between 600 and 700, our average rate right in that mid 600s. And then for those providers that are getting a really good 3.5, we're seeing in the low thousands on that upper bound. So there's definitely room on residential. We know the cost of residential, it's certainly not where the Medicaid rates are across the country in the 3s and 4s. But we also know that the cost to deliver residential is most likely in most markets not in the 6s or 7s either, to deliver quality care. And so we hope that some of these findings from this report can start to drive those rates much more closer to that upper bound target, and provide the evidence that the carriers are indeed reimbursing at that level, and they are recognizing that the cost of delivery of residential care is greater than perhaps where they started. And this is where there's no Medicare benchmark. So a lot of carriers started at a Medicaid benchmark. And if you've been in a contract for a long time with a carrier and you started around the Medicaid rate, that doesn't necessarily justify them and their 3% year over year. Your erroneous baseline, as I like to say, is not should be irrelevant with the insurance carrier versus what the current market is showing. Just because a provider opened its doors 2 years ago and got a contract in the upper bound, and you locked into a contract and a partnership with a carrier 10, 15 years ago, and you're stuck on this erroneous baseline. This data hopefully can unlock that argument for you, and move the conversation to a different place. The withdrawal management is also a fairly unstable, like PHP. It's a little bit tricky between how carriers are doing the payments in terms of what's 3.7, what's 3.5. But you can see certainly they're valuing withdrawal management at higher rates. And this is a good level of care if you offer it to compare to the hospital data that's in the national benchmark report, where you can see that even though these rates are higher in that 1,600 on the upper bound side, they're far below the per diem that a hospital might get for an ASAM level 4. And we know that obviously patients who are receiving ASAM level 4 in a hospital versus patients receiving ASAM level 3-7. There's some flexibility and mobility of those patient types depending on the level of capabilities of a given program. So, certainly can impress that upon the carriers that they could be saving, even contracting you at a quality rate, but saving money through, because for most people with commercial health insurance, the hospital is in network, and sometimes the community-based facility is not. And so somebody can be getting ASAM 4.0 in a hospital and pay less personally than they would pay for 3.7 at a network at a community-based facility, despite the employer and the health insurance company paying double or triple for the cost of care. And so once we released that report, a lot of questions came in around, well, what about this state? Or, in my market, these look different than my market, my individual market. And so we said, okay, well, let's see what the state level data looks like that's different than the national report, because we do understand that insurance is a state by state license. And so we had picked these 4 states. It's the states with large NAATP membership, and we wanted to analyze that. And so we've now published four discrete reports, and we're looking to build a more interactive opportunity potentially in the coming months to be able to look at the other states and even go more granular beyond what's in these reports. And so we're looking to continue to advance this. And so I'll go through a couple slides on each state. I'll go through these fairly quickly. Obviously, the data is available to you through the NAATP website. So there's about 1,269 providers. We're showing Kaiser in California. So we didn't do Kaiser in the national report, but because it's California, we wanted to publish Kaiser here, given their market share. And so a lot of this shifts based on the insurance carrier's market share in a given state. And so, where Cigna has less of a market share, we weren't able to kind of find enough data to validate a PHP level of care for Cigna here. So we don't publish it if we're not confident about it. But for all the other carriers, we're publishing kind of what we're confident about on their IOP side. And certainly for many of you who don't work in California, you look at these rates and you're like, wow, I want to open up in California. But then, if you look at the cost side of operating in California, there's some justification here of why these rates are going to be much higher and different than what you're going to see in some of the other states. And so one of the things that we're publishing in these state reports there's some case rates. And so in California, Blue Cross Blue Shield is buying some residential case rates, and we do a lot with value-based care. And so this is really interesting data points for us for 19,500 an in-network case rate for residential care in California. A couple of providers have that, and and certainly Kaiser and Aetna. We're not quite sure, the length of stay for some of those other case rates, but we try to identify that with an asterisk when we're publishing the top rates. But certainly, if you're contracting only on a per diem basis, again, that mode and upper bound set of numbers is worth staying focused on. And then you can see the ASAM 3.7 rates fairly consistent here in California. All right, we're going to jump to Florida next. So in Florida, it's dominated obviously by Blue Cross of Florida. On the IOP side, we see that Aetna is a decent payer, but Blue Cross, Cigna, Optum, all in those 400, in terms of the top rates on that side. For PHP, always a wide variance on what the carriers are covering there. We got about 927 providers in Florida that are rolling up into these data sets here. And then on the residential side, we are, Blue Cross is pretty stable in terms of, Blue Cross is pretty stable in terms of, what we're seeing between the peak of the distribution and the mode towards the upper bound. Certainly more variability in the smaller insurance plans in the state, but a bigger upside sometimes depending on the carrier. And withdrawal management, much lower rates than California, but certainly still significant opportunities. And let's see here. And then I'll breeze through this because it's a lot of numbers, but Pennsylvania, so we did Pennsylvania, they have a lot of different Blues plans. So we rolled them up together in Pennsylvania. Obviously, there's a lot of carve outs and other things that go on in Pennsylvania. And so we're looking at kind of an interesting picture on the IOP side, and certainly on the PHP side. But you see some rate suppression and in states that have significant numbers of carve outs, and that's because the risk-bearing entity on the behavioral health side is only accountable for utilization of the behavioral health spend, and they're not necessarily looking at the picture of the total cost of care. So you do see some rate suppression where there's significant carve out rates. In terms of 3.5, you're seeing still some consistency around the same national benchmarks, a little lower on the mode side for ASAM 3.5, but the upper bounds kind of are getting closer, but certainly a state with some lower rates than we saw in California and Florida in that regard, and certainly some interesting swings on the ASAM 3.7 side. In Illinois, we just published an update to this report because Blue Cross was inversing for 3.5 and 3.7. They were inverting the rate codes, and so we verified that with some NAATP members, and we're able to correct it in the updated report. So we're able to kind of correct those things on the back end, even when the carrier is making a mistake in terms of the rates, and we were able to verify that and make those adjustments for that. But that's get me through all the numbers, and so I'll just wrap up with a few kind of more philosophical positions and how to use some of this data. So once you dig in and look at the data, you part of it is really figuring out your story, how to tell your story of an organization. Many of our NAATP members don't have huge market share or huge leverage in terms of volume to an individual insurance carrier. So your threats of going out of network, or your threats of standoff negotiations may not always be as valuable versus talking through what the employers need, what the community needs, who you're serving, getting employers on your side. This is one thing that I talk a lot about with NAATP members, is one thing that if you're not doing, if you take one thing from this webinar that you should be doing, if you're collecting insurance cards and you're not collecting group numbers, I encourage you all to go ask your IT departments to add group numbers to your data collection process. And that's important because if you don't know who's paying for your patient's insurance, you lose a leverage point. And so the way that insurance works for those that are getting insurance through an employer, their employer is buying the insurance on their behalf. If it's a large employer, they're actually funding the entire insurance policy for the vast majority of Americans. And if you're having trouble in your telling your story and your negotiations, um, going to the insurance company's customers is a really strong way to increase your leverage. But if you don't know who's buying the insurance policies for your patients, you don't necessarily have that same, you have, 30% United patients and 20% Aetna patients and so on, but you don't know who the underlying employer is. It leaves you without that card to play, if you will. Um, and I think that more than anything, obviously leading with the data, leading with your qualitative data, how your services are benefiting, the evidence base behind your services. That's all very important for the carriers. But I think when we get down to it, these are large companies looking at large data sets. And so being able to take this rate data, look at the market share, look at who's in network in your community, um, you know, how quickly you're able to see patients, how you reduce ER use, hospital use, the behavioral health outcomes, patient satisfaction, all of those things that Marv will talk a little bit about with what NAATP's doing with Force, but that all becomes part of the leverage in terms of getting to a better rate or getting to an in-network contract, is your ability to increase the benefit for their customers and the network access for their customers. And so before you enter your negotiations, kind of understanding your own rates, understanding where the market is, this data, versus being reactive to what an insurance company pushes towards you, you're able to now go forward to a conversation knowing what they're paying other people and knowing what the market will bear. And so you'll know how to better demonstrate your impact through your own data, but also how to develop a partnership and a collaborator. Obviously, the relationships between the network folks and the providers is really important. Any unique offerings that you offer, whether it's adolescent treatment services or gender-specific treatment services, or other kind of specialty treatment, is really valuable to the carriers. Co-occurring certainly is a really valuable type of care, and that you're ultimately you and the payers and the employers have the same goal, to improve health outcomes for their beneficiaries, and so being able to tell that story. And with that, I'm going to kick it back to Marv to talk a little bit about NAATP's work with Force. He'll wind us down, and then we'll be open for dialogue and questions and answers. But thanks so much for letting me present some of this data to you.
Thank you very much, Greg. Yeah, there's a lot of numbers here, and it's a lot to digest. Greg lives in this. We live in it a little bit. For those of you who are sort of looking at it for the first time, it's a lot. But that's why we record these webinars, and that's why the reports exist in the format that they do. So as I said at the outset, our goal here is to align good care with fair reimbursement. And part of that is relationships with payers. Part of that is uh, producing good care. But the other piece of it is demonstrating good care to the payers, to the public, to everyone. And that's where outcomes comes into play. We can't do this. Providers can't be ultimately as successful as we need to be unless we can demonstrate that our outcomes are effective. And that's really what the Force program is about. So I want you, if you have some time, to take a look at the NAATP website, take a look at the Force website, Foundation for Recovery Science and Education, and look into participating. It does not cost members anything to participate and receive the core benefits. And ultimately, what we want to be able to say is, look, NAATP members are the best providers in the country. And among NAATP members, the best are those who track their outcomes and demonstrate the efficacy of their care. And that's really what Force is all about. And that's why we built it. That's why we're producing the reports, and that's why so many of you are participating. So ultimately, the goal is to connect those things. Say, look at these reimbursement rates benchmarked against others. Look at how we perform relative to outcomes benchmarked against others. And when we can do those things, we have the greatest leverage in terms of obtaining fair access and providing best access to care for those who need it. So, one other thing I would say that I just thought of during the session when Greg was talking, I think many of you probably saw that NAATP was in Washington last week, or was it the week before? Time flies. In the last couple of weeks, meeting with federal officials and other national policymakers, and I was there and I met with Secretary Kennedy, Dr. Oz, incoming Director Westlake, and many of the other policymakers, including folks from ABHW. That's the Association for Behavioral Health and Wellness. That is sort of the provider counterpart to NAATP. So we're a trade association, if you will, for the providers. ABHW serves that role for many millions of covered lives for the payers. And we've worked collegially with ABHW over the years. It's been a little while. I talked to their director recently, and we're going to meet in the next week to again communicate the need for these collaborations. And one of the things that we're talking to ABHW about is to talk to their payers about the force data as it is benchmarked against the national payer rates and the state payer rates. So that's an exciting piece. What also came out of that federal meeting, though, which does not admittedly have the force and effect of law and policy, is a pledge to pursue high quality care and produce access to care. So I asked our team just now while we were doing all this, if we could put up a slide here. Let me see if I can share um, uh, um, this slide real quickly. Yes, I think I can. Um, it's my desktop, so forgive the crudeness of it. But this is the behavioral health pledge that the Substance Abuse and Mental Health Service Administration, Health and Human Services, obligated itself to in terms of its intention, and asked all of us to do the same. And I think it's a big deal. I think that the fact that these six items, these six pledge items, are the core beliefs in many ways of NAATP and good providers, and that the federal government has said, let's do this together, let's agree to be part of this, it is the right direction, and we haven't honestly had this direction before. So individuals and treatment centers can also partake in this pledge, but the six elements are timely access to high quality mental health and addiction treatment, measurement of quality outcomes, accountability, and continuous improvement. There's our FORCE program and our quality assurance guidebook. NAATP has a quality assurance guidebook with 12 core competencies of providing good addiction care that's available to members. Clinical expertise and individualized treatment decisions based on patient needs and the best available evidence. Evidence-based assessment, diagnosis, treatment, referral, and recovery support. Patient-centered, recovery-focused care that supports long-term wellness. Whole person care is delivered, including addressing other chronic diseases. These are progressive things. This is not what maybe sometimes we think we're hearing out of Washington, but this is what Washington has produced as its belief system at this point in time, and I'm encouraged by all of that. So I wanted to mention that it's all part of getting to the place where we're trying to go. With that, I'm going to stop sharing. And Greg, if you can put up that last slide, if we still have that last slide, we can take a look at that. And I'll close, and then hopefully you've got questions. So I wanted to let you know about a couple of upcoming events. In addition to webinars, we have M to M's, which are member to member discussion forums, and C to C's, which are CEO to CEO discussion forums. And speaking of Force, the next M to M on September 24th is Force Collaborative for Data Site Providers. So Dr. Peters is going to meet with the data site providers to interpret the information that's coming out. And then please mark your calendars, finally, for our national event. Every year for nearly 50 years, NAATP has conducted a national conference where our members and the country's treatment provider leadership has come to share information and to learn. And that is it's always in May, and we'll be in Washington, D.C. this May, the 23rd through the 26th for our conference. So please mark your calendars and hopefully we can see you there. And when we're in Washington as a community, which we are every few years, we also like to hold a Hill Day where we literally take our members to the Hill to meet with their representatives, their policymakers. It's a very powerful event. Our members who have done this historically have said it was one of the most powerful things they've ever participated in. Individually, it's pretty tough to get Congress's attention, but as a collective, we seem to be able to do that. So we will follow the national conference this year with a Hill Day on May 26th. So plan to stay longer. And that's all I have, Greg. So we're going to turn it back to the group and to you. And I think that Zane Strand on our staff has been collecting. If there are questions or comments, Zane's been collecting those. So I will step back again, Zane, and let you and Greg manage the rest of this. Thanks, folks.
All right. Yeah, we don't have any open questions right now. So
That's a
if
shock. We
anybody
usually
has
have more than we can
questions,
manage.
please submit them right now.
We do have one that just came in, Zane, if I can pop in. For members who've never used benchmark data in negotiation before, likely most, what's the first smallest step that they should be able to take with this report?
Yeah, thanks, Crystal. Well, first and foremost, it obviously understanding your own self-awareness position in the market in terms of your size, are you in network or out of network? And so, that if you think about it as a decision tree, if you're currently out of network and you just thought that out of network reimbursement is the right model for you, hopefully this data will make you model it out, think about it twice. Certainly, we understand that the cost of patient acquisition and marketing and all the things that are required in order to maintain a census in an out-of-network model. And perhaps those costs, when you look, you still might be seeing a better reimbursement rate on an out-of-network. But if you start to map and model all of the costs involved in an out-of-network model and patient acquisition, there might be some rates that you see in these reports that make you go, huh, maybe taking a little less going in network might improve the business administration side, because obviously there's a lot of administration as well in an out-of-network model. And so if you are in network and already have a contract with a given carrier, or a carrier that you're out of network with, but you want to go in network with, this data hopefully will give you an opening point of view of where you want to start with. Often the carriers will send you a form or ask you what you're looking for. And historically, we've never had anything to benchmark against. And so our opening with carriers often is not within the wheelhouse of reality, or it's not within proximity to the current market. And or if they're the ones who are offering the initial rate, it gives you a point of view of what value they're placing your organization at, knowing what they're paying in the rest of the market. So So it really depends, I think, on your individual use case and your individual business. But hopefully there's use cases for all types.
Yeah, Greg, and I would add on to that, and it relates to a question that then just came up from an anonymous attendee. Have you seen members successfully use measurement-based care data to negotiate their rates? So that kind of combines the measurement-based. I think you're talking about outcomes data in that case, not specifically just the reimbursement rate. So what I can say in perhaps complement to what Greg said is we don't see these data as a hammer to be used. I don't think these reports provide you with this massive hammer that you can force opinions on your payers with. That's not the approach. It provides you with the opportunity to dialogue in a way that I think hasn't happened before. So if you were at the national conference in Florida this last year, Greg presented with one of our colleagues, Lee Peterson, who is an expert in reimbursement matters, and it continues to help us with these things. And he talks about how important it is to take this data and outcomes data together and meet and say, help me understand how we can talk about this information. We think we're doing a really good job. Here's where we're at with rates. Here's what we've got in terms of our outcome data. Let's have an open and progressive dialogue about this. That's the way that Lee has approached that, and I think he will tell you that he and others have been successful. We've had a number. I will tell you, I don't think it's probably appropriate to give you names and treatment programs, but yes, we have had members come to us and say we have been successful using our force data to improve rates with our payers. That has in fact happened. And then the last piece of that I might say is one of the things that NAATP does, I think, well, it is convene our members to talk to each other, right? So it's not just Greg or I or someone or Lee or someone else talking to you about what this is, but it's talking to your colleagues about their experiences. And there's a lot of sick people to go around. Yes, you all are competitors. That's true. But in a competitive environment, there's a massive amount of room for collaboration, and you see that with the NAATP community. So when we hold M to M's and you get to know one another, members share their own experiences. If you have successes and failures, I would encourage you to share those with your colleagues at NAATP, and others will do the same. So a lot of progress can be made that way.
Thanks, Marvin. We had another question come in. Are there levels of care where you're seeing the widest spread between payers? And what does that tell a provider about where to focus?
Yeah, it's a great question. And just the one follow-up to what Marv said, I would say, in terms of outcome measures, I've seen it where, folks that are being paid in the average or the median, have good outcomes, can get to the upper bound or to the top in their given market. And that's what the payers are looking for. It's like value. And, if you're licensed and credentialed and you meet all their criteria, you can get to the middle of the market, but to get to the upper part of the market, you definitely have to just demonstrate value and outcomes, for sure. And then Crystal, on the levels of care, I'd say without a doubt, it is that PHP. I think we see the largest swings. Different insurance companies have different points of view, I think, around PHP and the value of that and how it's delivered in a given state. It's certainly licensed and credentialed a little bit different in different states. I think we see a lot more consistency in IOP, the intensive outpatient level of care, the residential level of care, and the withdrawal management, and certainly a lot of consistency in the ASAM 4.0 level of care. So I'd certainly say that the partial hospital is one of those that you really want to kind of look at in a local market view.
Thanks for that, Greg. Now, I want to pull out real quickly in the last 5 minutes that we have left and consider how this connects to NAATP's broader access and sustainability work, Marvin. Um, what does NAATP do with this data at the policy level?
You're on mute, Marv.
I got excited and started talking. We meet with Congress, and we meet with the payers, and describe the work that we're doing and talk about our members. Our job is to really distinguish our members from the herd, if you will, and we're able to do that through a number of our resources. This is to the public, this is to the payers, and this is to the policymakers. We think about it in those three ways. Mark Dunn is our Director of Public Policy in Washington, and he has many reports about members of Congress relying on NAATP material, specifically our Quality Assurance Guidebook, which again, these are the core competencies. Um, they listen to us. Congress listens to us. I testified before Congress back in the ethics crisis, not that there still aren't ethics concerns, but back in the height of what we thought of as the ethics crisis. A lot of enforceable federal law and policy came out of that as a result of NAATP's access. So we do it to we analyze the data crystal in order to understand it better, communicate what it is to our members, provide members the resources they need with it, and then on the advocacy side, advocate with the stakeholders on that end on behalf of our members. Is that the kind of thing you were looking for, Crystal?
I think so.
Yeah.
Can you talk about what's next in the timeline? We have 4 specific state reports. So what's gonna happen next?
Well, ideally, so we're doing this in phases in order to see what works, what's helpful, and hear from you. So one of the things that has to happen for this to move forward is we need to hear from you. So the national report and the 4 state reports that are out there um, have gained traction. The state reports have not been out very long, so now we're really starting to see some traction. We want to see how they're used and how well they work, what the pros and cons are before we move forward with the next states. But the project all along, the goal has been to produce a report for every jurisdiction. And we're not, again, Greg is very thoughtful about how to learn from what's working and best and what needs to be changed. So we're gonna kind of pause a little bit to see how these reports are working out, and then stay tuned. I do think the long-term result will be that we produce state reports for every state.
Yeah. Absolutely.
It's a big project. It's a big and costly project, and we couldn't do it without Third Horizon. So we're grateful to you, Greg.
Well, it's a pleasure to be able to unpack this data for a community that really needs it. I think transparency and coverage has been out for a couple of years, and we know the hospitals and the specialists are using it considerably, and the payers are using it too. Like that's, the other side of this is, Aetna now sees Cigna's rates, and Cigna now sees United's rates, and and they didn't have that information on the payer side either. And so it's going to be an interesting few years in terms of how transparency changes this market, and hopefully with more sunlight, more access, more quality, and more sustainability, because it's certainly an important area of healthcare that needs attention.
Yeah, and historically, in this marketplace, negotiations have been unilateral, right? They've been dominated by one side of the equation, the payers, and providers have been an extraordinary disadvantage in that regard. So Greg likes to use the term democratizing care, and also the result being bilateral negotiations, and again, that's not adversarial. It's just good negotiation.
Yeah. Thank you, Marv, for having me today, and really appreciated the opportunity to share this with the community.
Yep, it's good to do good work together. I'm gonna wind up by saying thank you to everybody. Feel free to follow up with us with any questions that you have. Look in your inboxes for a follow-up from our staff in the next days, following up on this webinar with additional materials, and we'll see you next time. Thanks, everybody.